Good afternoon. In the next 25 minutes, I'll try to walk you through the present and future of endoscopy in Crohn's disease. And this is the issues to consider. We'll talk about the role of conventional colonoscopy, endoscopy in Crohn's disease. We'll talk about capsule endoscopy in understanding known established Crohn's disease. And we'll talk a little bit about a new capsule, the Pilcam Crohn's capsule. And let's start with establishing the diagnosis of Crohn's disease on endoscopy. The echo statements are very clear. You do an ileocolonoscopy and take 2 biopsies from 6 places. Let's talk a little bit about endoscopic activity and assessment of endoscopic activity and severity. Well, here we use the Crohn's disease endoscopic index of severity. Or the simple endoscopic index, in which we describe the elementary lesions in each segment, and we estimate the surface of the lesions and the ulcerations in each segment. This is how it looks. We have the 5 segments: the ileum, the right colon, the transverse, the left colon, and the rectum. And we give points for deep ulcerations, for superficial ulcerations, for surface of ulcerations, surface of the lesions. Altogether, we can get an index of 0 to 40. But unfortunately, and this is known for many years in the colon and terminal ileum, Crohn's disease clinical activity seems to be virtually independent of the disease severity of the mucosal lesions. You can have lesions and feel excellent. So this is why the statements say that the endoscopic index of Crohn's disease index of severity and is validated and reproducible, but its use in routine settings is still to be determined. And that there's no validation or definition of mucosal healing that is accepted by everyone. Let's move to the impact of endoscopy on therapeutic decisions. Early intervention and for whom? We all are aware that there are 3 strategies nowadays: the conventional step-up strategy, the accelerated step-up strategy, and the early top-down strategy. So we need to decide what to choose in each patient. So post-surgery, it's really simple. The Rutgers score is well known and well established post-ileocecal resection. And we know nowadays that Rutgers 2 or more, like you see here, the Rutgers 2 or more is associated with clinical endoscopic relapse over the years. So if we do this 6 months post-surgery, this is what is recommended, and by the score you decide if to treat and to step up with treatment. The next is, what about the colon itself? Is there a prognostic tool in the non-operated patients? Well, this is the study, a retrospective study from France by Mathieu Allais. 102 patients that were followed for 52 months, and 37 underwent colectomy. And you see that the relative risk for surgery, colectomy in patients with deep or severe endoscopic lesions, those that have deep ulcerations covering more than 10% of their mucosal surface, is 5.5 the relative risk. And you can see it very nicely here in this. This is those with severe lesions, those without, those with 1, 2, and 3 years ago. Another point is mucosal healing. We're all aware that the earlier we start with our treatments, the more mucosal healing we can get. We're also aware that the use of both infliximab and azathioprine increases the rate of this mucosal healing. And here in this multivariant analysis of factors that predict relapse, you see that if the Crohn's disease index of severity is more than 0, then the odds ratio, the hazard ratio is 2.6 for relapse. So the ECHO statement again says that achieving mucosal healing in Crohn's disease therapy is associated with a short-term decrease in relapse and hospitalization and need for surgery. So what have we learned so far? We learned that endoscopy provides a direct evaluation of mucosal lesions in IBD, permitting the description of elementary lesions, their surface and their severity, that it may help identify aggressive behavior of the disease, and that mucosal healing is associated with better outcome. But this is all true for the colon. Is this true also for the small bowel, as 80% of our patients have small bowel disease as well? So let's look a little bit into the role of capsule endoscopy in established Crohn's disease. The statements so far are not permissive. They confine our use of capsule in Crohn's disease patients only to patients with unexplained iron deficiency anemia or obscure GI bleeding. They don't recommend its use to everybody. Moreover, they say that before you use a capsule, do a cross-sectional imaging or a patency capsule to make sure there's no stricture. But we can think of other potential roles of capsule endoscopy in established Crohn's. If you want to stratify your patients into low versus high risk, you need to know their disease severity and distribution. The same thing is if you want a therapeutic plan, if you want to treat to target, if you want to reach mucosal healing, you need to know disease activity and severity. And you can also use it as a prognostic tool before, after surgery, or after treatment. So, but still, again, I want to emphasize, is mucosal healing important? As I said before, yes, it goes with less hospitalization, more steroid-free remission, and less surgery. And you see it very nicely in this slide. Those that are in mucosal healing stay in mucosal healing for a long time. And those that have complete mucosal healing have less surgery. But look at this, also those with partial mucosal healing. And this is translated into money. Patients in mucosal healing or in deep remission cost half to your government than those that are with active disease. So which prognostic factor to use? Clinical, endoscopic, imaging, genetic, serologic, or fecal calprotectin? Well, we in Sheba started a prospective study that is finished now to examine if periodic capsule in conjunction with MRE inflammatory markers and immunology phenotyping, can predict imminent flares and complications in Crohn's disease. Another thing we wanted to see is to evaluate the prevalence of active inflammation and mucosal healing in these patients using biomarkers, capsule and MRE, and to evaluate the impact of capsule and MRE on disease reclassification. So we recruited 80 patients, steroid-free remission, and we followed them cross-sectionally, prospective, non-interventionally for 3 years. We started with MRE, followed by a patency capsule, and if patency was proven, we did either PILCAM SB3 or PILCAM colon 2 at inclusion, and then every 6 months, the capsule, and 1 year, the MRE. And this was complemented by extensive laboratory work with CRP, fecal calprotectin, etc., every 3 months. These were our definitions. Clinical remission was CDAI below 150. Biomarker remission was CRP, normal CRP and fecal calprotectin. And mucosal healing was Lewis score, the inflammatory score in the capsule, less than 135. And if all these existed, this was deep remission or deep biological remission. So since we used the MRI as the first examination, we could answer the question, is MRE or a patency capsule better for prediction of capsule retention? And what we saw is that if we used MRE as the predictor, we wouldn't use regular capsule in 50% of our patients. But really, there was only 19% capsule retention if we used the patency. If we used patency capsule, there was only 19% retention rate. Okay, this was the study flow. You see, we started with 89 patients. 62 actually swallowed the regular capsule, and they were followed for 2 years, and we ended up with 34 patients after 2 years. You see that we altogether 232 capsules, no capsule retention and no problems. So, what do we really know about our patients? Do we know our patients? Those with small bowel Crohn's disease, and this is based on the baseline examination at entry. Well, we really don't know our patients. If you look at our patients that were in clinical remission, we see that 85% of them had endoscopic lesions by capsule or by MRE. 64 had mild disease according to the capsule, 21 had moderate to severe disease. And even if we took those in clinical and biomarker remission, still 62% with mild disease, 5% with moderate to severe disease. And if we want to know how many of our patients were in deep remission, and I didn't tell you, but 50% of our patients were on azathioprine, 40% were on anti-TNF agents, but only 13% of them were in true deep remission. So we concluded that clinical evaluation and inflammatory biomarkers severely underestimate the degree of small bowel and colonic mucosal inflammation. What do we know about the patient's phenotype if we use capsule and MRE? So again, the aim of this was to evaluate the impact of MRE and capsule on disease classification compared to the original thorough assessment we had. And this is partly evoked by this paper by Flamand that shows that if you have jejunal lesions in small bowel, this is a severe prognostic sign. So these are our patients before entering the study. This is after the first capsule and MRE. You see a jump in proximal disease from 11 to 51%. And you see here that the capsule was significantly better than MRE for proximal small bowel disease. The same thing with the phenotype. The stricturing phenotype increased from 31% to 60% using capsule and MRE. And here the MRE was significantly better than the capsule, not surprisingly. But you can say to the patient, take this, follow that, but you need to check the patient acceptability. Because if you want to give something to a patient every 6 months, he needs to be willing to take it. And you see that 78% of our patients prefer to repeat the capsule versus 22% that wanted to repeat MRE. And last but not least, can the capsule predict outcome? And you see here that 28% of our patients flared within that 24 months of follow-up, mainly in the 6 to 12 months, first 6 to 12 months. And you see here that the only factor, single factor, that predicted flare was a capsule, a Lewis score of above 350 in the worst segment, with a relative risk of 7.2 and a hazard ratio of 10. Or even better, Lewis above 330 in the second, that is the jejunal segment. So, to summarize this part, small bowel inflammation is detected in the majority of our Crohn's disease patients. Deep remission is rare. Capsule endoscopy and MRE changed the original classification in 60% of our patients. The capsule being more sensitive for proximal small bowel disease. And when used smartly, it is a safe and well-tolerated procedure in these patients. So taken together, these findings with the colonic findings led to the concept that one needs one pill to view the entire gut and to monitor disease activity. Up to a few months ago, the only way was to activate early the PILCAM colon 2. But Medtronic picked up the glove, and we have now this new pill, the PILCAM Crohn's. It's very similar to the PILCAM colon 2, with the angle of view of 172 degrees, with an adaptive rate technology of 4 to 35 frames. But it starts working from the mouth to the anus, like the original capsule was called, M to A, mouth to anus. And it divides the small bowel and the colon into segments according to length and not according to time. The main difference from the PILCAM colon 2 is the software. This is a specialized, dedicated software for IBD. This is what some frames seen in this capsule, and you see that the frames are very nice. And this is this new software. This is how it looks. It has a GI table and a GI map. So every segment of the small bowel is divided automatically into 3 segments. And you mark the most severe lesion in each segment, the most typical lesion in each segment, and the extent of the disease in each segment. And this is reflected visually in the GI map. If you have a problem to decide if it's mild, moderate, or severe, you have a right click and you have an atlas showing you what is mild, moderate, or disease. And everything is recorded and in the software and stays there forever. And the report is the usual report, but it has also the GI table and the GI map. And if you're a good doctor that writes the complaints of the patient, what he is treated with, what did you change in treatment, then, and you repeat the capsule, then you have this. So you can see this is the first study, and then from then he started on infliximab, and look what happened, he improved. So you have the complete record of the patient in your study. You know his complaints, you know his treatment, and you know his endoscopic activity. So this is very nice, the system is excellent, but nobody tested it. So this is the proof of concept study we're going to present in the UEGW next at the end of this month. It was a multi-center prospective feasibility study, mainly of Crohn's disease patients, mainly with active Crohn's disease. And we wanted to examine the functionality of the system, the completion rate, the reading time, the quality of images, and the convenience and safety of the patients. So 49 patients completed the study. All the capsules reached the rectosigma or the toilet, 95% while photographing. The reading time was much shorter than PILCAM colon 2, and the pictures were of excellent quality. So to summarize this part and the end of my talk, the new panenteric capsule is safe in patients with suspected or known CD and actually UC as well. It may have an important role in assessing panenteric mucosal healing. The new software allows follow-up and comparison over time. Now I'm translating the Russian into English. It's so fast. And the capsule role in a screening tool to patients with suspected Crohn's disease needs further evaluation. So, ladies and gentlemen, the future is bright. Don't be scared like these friends of mine that say that it's a bit freaky with this wireless technology. And I thank you for your attention.